The purpose of this video is to complete Chapter 14, the cervical and thoracic spine, as well as thoracic pathologies chapter from your book. As I believe I've explained, though, we are not going to spend much time on the thorax right now. That's going to come in our next unit when we talk about cardiac and lung conditions, so we'll put the thorax stuff in with that. We will be combining abdominal, cardiac, thoracic, and lung pathologies all together. That's just the way that I've found that it works better. So when we last talked about the cervical spine, we were having an online lecture, and I realized that some of you guys were having a struggle paying attention. So let me just give you an overview then of what we were doing. The first part of this unit, we were reviewing some anatomy. All right, so be sure that you are familiar with the structures, the atlas and the axis especially, that are formed differently than the vertebrae in the lower cervical spine, and that you know what supports the atlanto-occipital joint and the atlantoaxial. So ligamentous support is important here. Just a reminder, because we've already been over this, so you want to remember the transverse ligament, the alar ligament, and so forth. All right, so again, just a reminder of that functional anatomy. The discs in the cervical spine are both the same and different than the discs in the lumbar and thoracic. They're smaller, that's for sure, and that's because they support less weight. And also there aren't any discs at the atlantoaxial and atlanto-occipital joints. Other than that, they still have especially in the lower cervical spine, an annulus fibrosus surrounding the nucleus and so forth, just sort of typical disc characteristics. All right, review of ligamentous anatomy and neurological. Again, we've been over all of this. A reminder that you need to know your muscle attachments and be able to palpate them on your patient. Okay, we're skipping over the thorax for now. Okay, skipping over the abdomen. We're going to do that next week in a different unit, and it'll be our last unit. Looking at the last part of the anatomy is the neuroanatomy, and you guys have already learned your brachial plexus. I don't tend to test on that because you've already been evaluated on it. All right, in your history, the history of this of the cervical spine is in some ways a lot like the one for the lumbar and the thoracic spine. And you're asking about, the only difference would be you're asking about chest or breast pain and headaches. Headaches can certainly accompany a cervical spine injury that is especially a chronic one. You also want to ask about the eyes because eye strain can give a patient headaches, and that the headaches then could be referred into the cervical spine. So that may be the reason that the patient is having a cervical spine complaint. Psychosocial factors impact spine, chronic pain associated, or chronic pain that is spine related. So we always want to ask about those types of things as well. Okay, so history of mental illness is really what I'm talking about here. All right, so we talked about a lot of these conditions already: vertebral artery insufficiency, little nerve root dysfunction. You know, when you're doing your inspection, you need to look at the functional assessment, asking the patient to describe or reproduce the motions that cause the symptoms. As far as the work environment, we're always sensitive to patients who are doing overuse or repetitive stress types of things, be that working on an assembly line where they do the same things all the time, sitting at a desk that's not adjusted for them correctly, and those types of work factors. So any sort of repetitive stress that we can attribute to the neck pain. Cervical flexion and extension, looking for compensations when they're moving in these directions, is helpful also. Okay, we know we have to look at our patients from the lateral so that we evaluate the lordotic curve in the cervical spine. Also looking for forward head posture. Again, this is a review. I'll give you, you guys have the access to these slides and you can read them on your own. At the anterior, looking at the level of the shoulders, the position of the head. Don't forget that torticollis is where we have a spasm of the SCM, and that will cause the chin to rotate as well as appear to be side flexed. Okay, and there's some pictures of that. All right, continuing on the posterior structures, cervical musculature is of particular concern, looking for atrophy or increased tone, and you perhaps are going to see hypertrophy on the dominant side, but you're not going to see that in all your patients. All right, palpation, again, a review from what we did earlier in the semester. You need to be practicing this skill. I have already posted your cervical and thoracic spine worksheet, and these are some structures that you would need to be palpating. Okay, some landmarks. Again, all of this is review. As I discussed when we were talking about this last, we have a range of motion assessment. It could be very important for the cervical spine, and it can be done a number of ways. First of all, if the patient does their active range of motion and it appears to be normal, most of the time we would not measure that. You can use, though, you can see here the sternal notch or the manubrium, but I would say use the sternal notch for your landmark and measure rotation using a tape measure. Okay, you can measure flexion and extension the same way using the same landmark. You can also, when you're doing passive range of motion, it's important for your patient rather, to be supine on the table with the head off the table. And this is a very important aspect of our assessment. I would not measure this, but it is important to assess. Okay. Pay attention to, and this I've already been over this, but to what ligaments are on stretch when you move the patient into flexion and extension. And I'll let you look those up because they're important. Okay, we can the best way to do our cervical goniometry is to use the inclinometers. I actually have the inclinometers on a thing called a cervical range of motion assessment device, and I will demonstrate that when we meet again in class. Okay, so here's some other methods for using the bubble inclinometer. So this is going to be definitely the most accurate. Okay. Oh, here's those ligaments I was talking about. Maybe you want to pay attention to that because that's a couple questions on your quiz are coming from this slide right here. Okay. All right, we've talked about stenosis. We talked about the fact that the vertebral canal can become closed in or smaller due to osteophyte formation. We also see spurs growing on the facets right here. Okay, and then as a review, the Torg-Pavlov ratio is the ratio of the vertebral body to the canal. All right, so that can be false. That can give false positives if the vertebral bodies are overly large. And so a better way to do that is the space available for the cord. So again, SAC stands for space available for the cord. Anything that's smaller than 14 millimeters is considered pathological, is considered diagnostic for stenosis. Okay. This is the upper limb tension test. And so what we're doing here, just to give you a quick overview, and then we'll do this in class, is that you want to start this test if you're testing on, this is the patient's left side. The head is side flexed passively to the opposite side and the shoulder is depressed. Because it's a nerve tension test, you're looking for neurological symptoms that would be numbness, tingling, shooting pain down the shoulder and the arm. Okay, and then we're going to put the shoulder into slight abduction and then starting in internal and moving into external rotation. And on the next slide, we'll see that we then extend the elbow and extend the wrist. This is very much like the slump test because you're going to check with your patient at every step. And if they report positive neurological symptoms, then you stop. Okay. The Babinski and the Oppenheim's test could be appropriate for detecting an upper motor neuron lesion, which can happen in the cervical spine. So those would be appropriate tests if your patient is having some sort of diffuse and difficult to nail down types of neurological symptoms. Okay. Beaver sign for thoracic nerve inhibition is where the umbilicus is going to deviate, and that would be because a thoracic nerve is inhibited. So you want to have the patient do a curl up and observe the umbilicus. All right. Radiculopathy, the primary causes are disc herniation or osteophyte formation. We've talked a lot about radiculopathy in the lumbar spine, and there's really not any difference in the cervical. So it's a concept that we're already familiar with. The thing that can cause a radiculopathy, compression or forces that make the cervical spine go past its normal range of motion, which means if you're going past normal range, you need to rule out a catastrophic injury. And there's usually multiple structures involved in the neck pain. Spondylitis is where we have an osteoarthritic spine. So this is an active condition in which the patient is basically developing osteophytes or bone spurs on the vertebral bodies as well as other segments of the spine. The disc is becoming more narrow, and basically this patient would experience a lot of pain and dysfunction, possibly also instability because of this condition. All right. So again, spondylitis consistent with or pretty much synonymous with osteoarthritis in the spine. Okay. So here's our cervical nerve root compression sort of examination table, if you want to call it that. I encourage you to read over that so that you understand some reasons that we may suspect that our patient has nerve root compression. One of the key things is looking at the special tests, so cervical compression, cervical distraction, Sperling's, vertebral artery, and shoulder abduction. That's pretty much all of our cervical spine special tests, okay, that we're going to apply to our patient to figure out if they have a nerve root compression related to perhaps a disc injury or perhaps stenosis. Okay, so here is the cervical compression test. We're closing down the intervertebral joint, so putting pressure on that. We're also closing down those facet joints to see if there is perhaps going to be increased pressure on a cervical nerve root. Okay, Sperling's test is a different, it's very similar to the cervical compression test, except that we start with the patient in extension. If they don't experience any symptoms, then we go ahead and side flex, and then from side flex, we apply an axial load. All right, so you're going to simply put them into extension, evaluate for neurological symptoms, excuse me, and if they don't have those, go ahead and introduce the side flexion before you do the axial load, pushing straight down. Okay, so again, this is a test for disc injury, radiculopathy, perhaps stenosis in the intervertebral foramen. We can also do a distraction test to see if the patient has relief of their symptoms. Okay, so cervical distraction can be useful. I will demonstrate for you the vertebral artery test, which tests for deficiencies in blood flow through the vertebral artery. Your patient would experience dizziness and sort of this anxious feeling. The eyes may develop nystagmus with this decreased circulation. So we'll practice that one in class as well. All right, so disc pathology is most common at C5, C6, or C6, C7. So the lower part of our cervical spine is much more commonly the area that we would have a disc injury. So what you can see right here is if the disc protrudes directly posteriorly, the patient will develop a myelopathy because there's pressure on the spinal cord right here. More commonly, though, what you'll see is that it goes either to the left or right side, and sometimes both. So, this herniation is much bigger than this one. But that's a very typical pattern. Because of the position of the posterior longitudinal ligament, the disc material tends to go to the lateral side. All right, so our shoulder abduction test, the patient would put their hand on their head, and you would leave it for 30 seconds to see if they experience any pain relief in the area that they're having trouble. And that can be positive then for a disc injury. All right, degenerative joint disease, degenerative disc disease, as well as degenerative joint disease, which would be, the joint would be primarily the facet joints. Typically, this begins with disc degeneration, so the patient could complain of joint pain, of cervical stiffness, and they may demonstrate also limited active and passive range of motion. Okay. Clinical cervical instability may be something that you assess your patient. This is a little bit more of an advanced skill. It's not a gross instability. In other words, the patient is able to function normally, but just certain times they have periods of being tender to palpation and muscle spasm and poor control of the cervical spine in the mid-range of active movements. So this can be caused by poor posture, by repetitive movement, by muscular weakness, also possibly by damage to passive restraints. And so primarily those passive restraints are the ligaments. So we can have cervical instability just the same as we can have lumbar instability. I don't tend to emphasize that in your patients or in my teaching of this because, again, I feel like detecting that is a little bit more of an advanced skill. All right, facet joint dysfunction we have discussed. Keep in mind that either repetitive motion or something that's like a whiplash motion could affect our facet joints and cause that facet joint dysfunction. The concepts that we learned in the mechanical low back pain workshop would be applicable if our patients develop facet dysfunction in the cervical spine. So the signs and symptoms would be posterior neck pain during extension and rotation, clicking or catching, localized pain that's lateral to the spinous process. All right, so before I go on, then I'm about to run out of time in this segment. I'm going to go ahead and cut this segment off and finish up the last slides in part 2 of this lecture.